Good morning, Ms. Craig.
Good morning.
Your learning objectives for mastering the examination of the breasts and axillae are to describe male and female breast anatomy and changes with aging, to identify causes of breast masses and assess risk factors for breast cancer, including use of risk assessment tools, to apply screening recommendations for mammography, clinical breast exam, and self-breast examination appropriately, and to examine the female and male breast using recommended techniques. The female breast lies against the anterior thoracic wall, extending from the clavicle and the second rib down to the sixth rib. The breast is often divided into 4 quadrants based on horizontal and vertical lines crossing at the nipple: upper outer, upper inner, lower outer, and lower inner. A 5th area, an axillary tail of breast tissue termed the tail of Spence, extends laterally across the anterior axillary fold. The breast may also be visualized as a clock face, so that a lesion may be located by time, for example 3 o'clock, and by its distance in centimeters from the nipple. The female breast is composed of glandular tissue, which forms 15 to 20 septated lobules radiating around the areola, or nipple. These drain into milk-producing ducts and sinuses that open onto the surface of the areola. Fibrous connective tissue provides structural support in the form of fibrous bands or suspensory ligaments connected to both the skin and the underlying fascia. Fat, or adipose tissue, is also present, mostly in the superficial and peripheral areas. Both the nipple and the surrounding areola are supplied with smooth muscle that contracts to express milk from the ductal system during breastfeeding. Tactile stimulation of the breast, including the breast examination, may make the nipple smaller, firmer, and more erect, with puckering of the areola. These reflexes are normal and should not be mistaken for signs of breast disease. The male breast consists chiefly of a small nipple and areola, but lacks the development of lobules. It may be difficult to distinguish male breast tissue from the surrounding muscles of the chest wall. Of the axillary lymph nodes, the central nodes are palpable most frequently. They lie along the chest wall, usually high in the axilla and midway between the anterior and posterior axillary folds. The pectoral nodes anterior are located along the lower border of the pectoralis major, inside the anterior axillary folds. The subscapular nodes, posterior, are located along the lateral border of the scapula, palpated deep in the posterior axillary fold. Lymph drains from the central axillary nodes to the infraclavicular and supraclavicular nodes. Ask about the breasts during the history or later during the physical examination. Ask the patient,
Do you examine your breasts, and if so, how often?
For a menstruating woman, ask when she examines her breast during her monthly cycle. Self-examination is best done 5 to 7 days after the onset of menses, when estrogen levels are low. Common or concerning symptoms relating to the breasts and axillae include breast lump or mass, breast pain or discomfort, and nipple discharge. Ask the patient,
Have you had any discomfort, pain, or lumps in your breasts?
If your patient reports a lump or mass, ask about the precise location, how long it has been present, and any change in size or variation related to the menstrual cycle. Also ask about any change in breast contour, dimpling, swelling, or puckering of the skin over the breasts. Causes of breast masses include fibroadenoma, cysts, and malignancy, and vary with age, as shown in this table. Many women have palpable cystic changes or nodularity, and premenstrual enlargement and tenderness are common. Also ask about any discharge from the nipple and when it occurs. Women may experience a wide range of changes in breast tissue and sensation. They will frequently seek information during the clinical encounter. If a palpable mass is discovered, definitive diagnosis should be pursued. Breast cancer is the most common cause of cancer in women worldwide. 95% of new breast cancer cases occur after age 40, and as you can see from this chart, the probability of diagnosis increases as a woman ages. You should be familiar with the epidemiology of and risk factors for breast cancer that support recommendations for screening. You should also be familiar with the breast cancer risk assessment tools that are available. These include the Gale model, the Klaus model, and the BRCA-PRO model, all of which can help you clarify breast cancer risk for your patients. Since the 1980s, increased screening with mammography has resulted in rapid increases in detection of early-stage breast disorders. U.S. Preventive Services recommends individual decision-making for women under the age of 50 as to when to begin having mammograms, usually at age 40. You should be prepared to offer counsel as the patient strives to make an informed decision. With the patient's health history in mind, and after good hand hygiene, you are ready for the physical examination. During examinations of a sensitive nature, including those of male or female genitalia, it is important to observe the policies of your facility pertaining to privacy and confidentiality. Therefore, request a chaperone during your examination when indicated, such as a nurse or other health provider. To begin the examination, visually inspect the breasts with the patient seated and her arms at her sides. Inspect the appearance of the skin over the breasts, noting the color, any thickening of the skin, and unusually prominent pores, which may accompany lymphatic obstruction. Also, observe the breasts for symmetry of shape and size. Some difference in size is common and usually normal. Then, inspect the contour of each breast carefully to detect any masses, dimpling, or flattening. Compare one side to the other. Next, inspect the nipples, noting their size and shape. Look for rashes, ulceration, discharge, or any asymmetry in the direction in which the nipples point. Occasionally, the nipple is inverted, which is of no clinical consequence, except for difficulty during breastfeeding. Ask the patient to raise her arms over her head to bring out skin dimpling or retraction that may otherwise be invisible. Next, ask the patient to press her hands against her hips to contract the pectoral muscles. Inspect the breast contours carefully in each position. If the breasts are large or pendulous, it may be useful to have the patient stand and lean forward, supported by the back of a chair or the examiner's hands. Dimpling or retraction of the breasts in these positions suggests a possible underlying cancer and should always be evaluated further. Palpation is best performed when the breast tissue is flattened. With the patient lying down, drape the left chest and examine the lateral portion of the right breast. Ask the patient to roll onto the opposite hip, placing her hand on her forehead, but keeping her shoulders pressed against the bed or examining table. Begin palpation in the axilla, moving in a straight line down to the bra line. Then, using the pads of the second, third, and fourth fingers, move the fingers medially and palpate in a vertical strip up the chest to the clavicle. Palpate in small concentric circles, moving in vertical overlapping strips until you meet the nipple. To examine the medial portion of the breast, ask the patient to lie with her shoulders flat on the examining table. Adjust the drapes and place her hand at her neck, lifting up her elbow until it is even with her shoulder. Palpate in a straight line between the nipple and bra line, then up to the clavicle, continuing in vertical overlapping strips to the mid-sternum. Examine the breast tissue carefully for consistency of the tissues, remembering that consistency varies widely depending on the proportions of glandular tissue and fat. Note any tenderness, as in premenstrual fullness, Assess and describe the characteristics of any nodules, including the location by quadrant or clock with centimeters from the nipple. Describe the size in centimeters, shape, be it round or cystic, disc-like or irregular in contour, consistency, is it soft, firm, or hard, delimitation, well circumscribed or not, tenderness, mobility. Gently move the breast near the mass and watch for dimpling. Try to move the mass itself while the patient relaxes her arm and then while she presses her hand against her hip. Next, palpate the nipple, noting its elasticity. Loss of elasticity suggests an underlying cancer. If there is a history of spontaneous nipple discharge, try to determine its origin by compressing the areola with your index finger, placed in radial positions around the nipple. Watch for discharge appearing through one of the duct openings on the nipple's surface. Note the color, consistency, and quantity of any discharge and the exact location where it appears. Although examination of the male breasts may be brief, it is important. Inspect the nipple, areola, and breast tissue for nodules, swelling, or ulcerations. If the breast appears enlarged, try to distinguish soft fat from the firm disc of glandular enlargement called gynecomastia. When assessing the axillae, a sitting position is preferable. Inspect the skin of each axilla, noting any evidence of rash, infection, or unusual pigmentation. To examine the left axilla, cup together the fingers of your right hand and reach as high as you can toward the apex of the axilla.
You may feel a little discomfort for a moment.
Okay.
Your fingers should lie directly behind the pectoral muscles, pointing toward the mid-clavicle. As you bring your fingers down, try to feel the central nodes against the chest wall. Feel for other groups of axillary nodes if the central nodes feel large, hard, or tender, or if there are suspicious lesions in their drainage area. For the pectoral nodes, grasp the anterior axillary fold between your thumb and fingers and palpate inside the border of the pectoral muscle. For the lateral nodes, feel high in the axilla along the upper humerus. For the subscapular nodes, feel with your fingers inside the muscle of the posterior axillary fold. Also feel for the infraclavicular nodes and re-examine for supraclavicular nodes. Repeat the axillary examination on the right side using your left hand. A high proportion of breast masses are detected by women examining their own breasts, so teaching your female patients the techniques of breast self-examination promotes self-awareness, even though statistically it may not change the rate of detection of malignancies. Lying supine with a pillow under the right shoulder and with the right arm behind her head, the patient should use the fingers of the left hand to examine the right breast. The patient should press firmly on the breast, making small rotary movements in the up and down strip pattern and checking the entire breast area while remembering how the breast feels from month to month. The breast self-examination should be repeated with the patient standing with one arm behind her head. The upright position makes it easier to check the upper outer part of the breast. And remember to tell the patient,
So if you find any changes, please contact my office immediately.
Okay.
remember that a clear, well-organized clinical record, employing language that is neutral, professional, and succinct, is one of the most important adjuncts to patient care.
Nipples without discharge, skin without dimpling or erythema, axillary lymph nodes normal in size.
After practice and further review of this video, make sure you have mastered the important learning objectives for examining a patient's breasts and axillae.